My name is Mike McNitt-Gray from UCLA, and the title of this presentation is Common Technical Mistakes and How to Avoid Them, Lessons Learned from the American College of Radiology CT Accreditation Program. Next. These are my disclosures. Next. The objective of this presentation is to understand the resources available for the ACR CT Accreditation Program, some of the common mistakes that are made in the physics or phantom component of that program, and to understand the steps to identify and rectify these mistakes prior to the scanning of phantoms and the submission of those materials. Next. Here are some of the resources that are available from the American College of Radiology's CT Accreditation Program. The fundamental website is this first one listed here under Accreditation/CT. There's also a link for the phantom testing instructions, and there's a link for the phantom data and dose forms, which are in the form of an Excel spreadsheet. And there's also a list of frequently asked questions that are available. And these are all under the ACR website, and these are great resources to consult as you're preparing for your ACR accreditation submission. Next. So the first part to consider is what we refer to as Table 1. It's a technical description of the site's protocols for the 4 scanning protocols that are to be submitted if sites use both adult and pediatric techniques. For the adult head, the guidance is to use the average parameters for the cerebrum portion of your facility's adult brain protocol. So these are obtained by looking at several examples and taking an average of particularly the MAS values there. The adult abdomen is similar, except you use the average technique used on a mid-liver range image on an average size patient for the adult's abdomen protocol of the site. If the site does pediatric head scanning, use the average parameters for the cerebrum portion of facility's pediatric brain protocol that is specific for about a 1-year-old. That's the size we're looking for in that submission. And for the pediatric abdomen, use the average mid-liver protocol for a pediatric abdomen on a 40-pound child, which is approximately a 5-year-old. Next, so Table 1. The goal there is to understand what the site really does clinically. Make sure that the lead radiologist and lead tech are consulted, and make sure they understand the importance of filling that out correctly, and the physicist should assist in helping them fill it out. This is a common area of mistakes, because if this table gives inconsistent data compared to the images that are submitted, the reviewers will find these discrepancies, and this can often lead to either deficiencies or sometimes a major deficiency and the failing of the ACR submission for the phantom portion. So first, the goal is to understand what the site really does in their clinical protocols and make sure that that's filled out correctly. Some of the common mistakes specifically are there's a row in the table for MA, and what sometimes sites do is enter MAS or the term effective MAS or MAS per slice, which I'll define in the next slide. So the physicist should help the site understand the difference between these and that they're not all equivalent, that MA and MAS are not the same, that MAS and effective MAS are not the same, and similarly with MAS per slice. Here are some of the definitions. Siemens uses the term effective MAS, and it's defined as I showed here. It's the tube current MA times the rotation time divided by the pitch. If you rearrange that equation, you can find the MA that's being used at that time, which is the effective MAS times the pitch divided by the rotation time. Similarly for Philips, they use the concept of MAS per slice. It's a similar definition, and that MAS per slice is MA times rotation time divided by pitch. And you can rearrange that similarly to obtain the MA that's being used by the scanner at that time. Toshiba and GE use MA, time, and pitch as separate values. They don't use the definitions of effective MAS or MAS per slice, so those should be really reasonably straightforward. In the Table 1, it does ask for effective MAS. That can be provided. If the scanner doesn't use the concept of effective MAS, you can leave that part blank. Next. Some common mistakes here include reporting the MAS or effective MAS or MAS per slice in Table 1 as I described. So using the MAS or effective MAS, when this is done in Table 1, if that's if those values are used when performing CTDI measurements, that can lead to a mistake. For example, if the scanner is a Siemens scanner and uses 200 effective MES, and for example a pitch of 0.9 and a rotation time of 0.5 seconds, if you use the equation on the previous slide, you can calculate the MA to be 360. When the scan is done for CTDI measurement, that CTDI measurement should be done with 360 MA, 0.5 second, or 180 MAS because it's a single axial scan. The spreadsheet will use the pitch 0.9 and correct for values of effective MAS. If the physicist does the measurement with effective MAS rather than MAS when doing the CTDI measurement, that'll lead to a mistake in the value of calculation of CTDI. Next. If the site does this incorrectly, this confusion between MAS, effective MAS, the spreadsheet will have incorrect values. For example, if they perform the acquisition with 200 MAS and then use the values in the spreadsheet for the dose calculation of N, T, and I, such that a pitch of 0.9 results, then the CTDI reported will be too high. If the pitch is less than 1, the CTDIvol value reported will be too high. If the pitch is greater than 1, then the CTDI value will actually reported will be too low. So it depends on the pitch value. But either way, if you use the effective MAS value instead of the MAS value, the CTDI value will be incorrect. Another common mistake is reporting the collimation incorrectly. And admittedly, this can be confusing for some scanners. For example, the Siemens Sensation 64, the scanner interface says 64 by 0.6. However, in that scanning mode, the scanner uses the Z-flying focal spot, which double samples on the Z-axis of the anode to obtain 2 times the images. The actual beam width uses an N, or number of data channels, of 32, and each data channel, or T, is 0.6 millimeters. For a pitch of 1.0, the table travel then will be 19.2 millimeters per rotation. Sometimes sites list this as N equals 64, which is incorrect, T equals 0.6, and then they'll put in an interval of 38.4 to indicate this is a pitch of 1.0, sorry. But the increment is actually 19.2 as indicated in the previous row. If these values carry over into the spreadsheet and that's used for calculating CTDIvol, then the CTDIvol value will be half of what it should be, and this leads to an incorrect value. Next. Some other column mistakes about reporting collimation correctly can be described. Some of them are described, and you can consult the ACR CT Accreditation website for those FAQs that were mentioned before. There's a discussion in there about several different scenarios for collimation and reporting it correctly. Next. Some other lessons. The CTDIvol limits. CTDIvol limits are established for the accreditation program, but for each of the 4 different exams that are submitted, there's a reference level, and then there's a pass-fail level. For adult head, the reference level is 75 milligray, and the pass-fail level is 80 milligray. Any submission with an adult head protocol of greater than 80 milligray is a fail. For adult abdomen, the reference level is 25 milligray, and the pass-fail level is 30 milligray. The next 2 are new limits that are just being established. They'll be effective July 1, 2013. For the pediatric or 5-year-old abdomen, the reference level is 15 milligray, and the pass-fail level is 20 milligray. That's a new value that's been recently introduced. It's lower than it was before. I think it was, anyway, there was a little bit, these are lower than what was previously done. The pediatric 1-year-old head the reference level is 35 milligray, and the pass-fail level is 40 milligray. Again, these values are new, and they've just been adjusted, and they will be effective July 1, 2013. So, this is known, this is in the instructions, that exceeding these dose limits leads to a failure. So, what happens? If the adult head is at the 80 milligray limit, here's some things to check. First, was the protocol followed and the scan done correctly? Was the KVP, MAS, collimation, were they done as described in Table 1 of the site submission? If yes, and the values are still exceeding 80 milligray, here's a couple more things to check. Is the site using the cerebrum technique Or are they using a different portion of the head exam technique? Is the site using too high a kVp? The doses are much higher at 140 kVp, so the site should be just consulted and see if they can use 120 kVp if they're using 140 kVp. If they want to use 140 kVp, then they should be consulted and asked if they can reduce the MAS for their routine head exam. This is not for specialty exams. This is for just a routine standard adult brain technique. Next. Okay. If these values are still exceeded and still greater than 80 milligray, a few more things to check. Is the MA or rotation time very high? If so, what's causing that? Why are those values being set? Why is the MA being set high, or why is the rotation time being set very high? If it's a helical scan, is a low pitch value being used? Some manufacturers recommend a low pitch value for their helical head scans. It gives better image quality, but the site should make sure that the MAS is reduced to compensate for that. And something else that should be consulted is the site using very thin slices for the routine head exams. If so, the increased noise in thin slices may be driving them to increase the MAS or to decrease the pitch. Again, some sites like to make very thin slice additional images for reformatting. That's fine, but we're talking about the study for which the primary diagnosis is being done. Those can often be done at 4 to 5 millimeter thick slices and still get very good image quality for the diagnosis. For the pediatric abdomen exam, the dose limit used to be 25 milligray. That's being reduced to 20 milligray. Some things to check there. Some sites lower the MA, but also decrease the pitch. And if they do that, that does not yield an intended net dose reduction. They may think they're getting a dose reduction because they lower the MA, but if they're using a scanner where the pitch and the MA are done separately, then decreasing the pitch and the MA simultaneously does not lead to a net dose reduction. So that's something to consider. Some sites use a lower kVp, but they'll keep the MAS and pitch the same. That lowering the kVp will yield a good dose savings. So that's something that should be considered, especially in pediatric abdomens for 5-year-olds. Next. Some other lessons. Low contrast to noise values. These are no longer major deficiencies. These are all minor deficiencies. But let's go through the exams and the limits. For the adult head, the low contrast test, the CNR value, the limit is 1.0. For the adult abdomen, its limit is also 1.0. For the pediatric abdomen, that limit has been reduced from 0.5 to now 0.4, and that will go into effect July 1, 2013 as well. Pediatric 1-year-old head has been reduced from 1.0 to 0.7. Again, the pediatric CNR values for both head and abdomen have been adjusted, and they're effective July 1st, 2013. Values below that listed criteria will result in only a minor deficiency. Some other potential mistakes for the low CNR values, some common reasons for those deficiencies. In trying to reduce the site, in trying to reduce the dose, the site may go too far and reduce the technique beyond what's reasonable. That increases the noise, resulting in low CNR values. This also happens when sites use very thin slices for routine abdomen or routine head. Again, having a secondary reconstruction for axials for sagittals or coronals is perfectly fine, but for primary diagnosis, these images usually should be a little thicker to reduce the noise, because using those thin slices will increase the noise, resulting in a low CNR value. Parameter mismatches are another area of common mistakes. Reviewers notice submissions that had parameters on the forms that did not match the actual scan parameters. So now, if the MAS is more than 10% different between the scan and what's listed in Table 1, this can be considered a major deficiency, which would lead to failure. So we're looking for consistency between Table 1 and the actual values of the phantom when it's scanned. And you can see the quote here from the ACR manual. Scanning the phantom with any deviation from the protocols recorded on that phantom data form, with the exceptions noted below, you can see in the instructions, may result in failure to achieve accreditation. So summary. First of all, thoroughly understand the protocols for each scanner. Make sure the Table 1 is filled out correctly. Report and verify scan parameters that are reported correctly in Table 1, and that those same parameters are used in the phantom scans. Ensure that CTDIvol values are within limits. If not, discuss the protocols with the site and about ways to reduce those CTDIvol values. And finally, ensure the CNR values are within limits. If not, discuss these protocols with the site. And that concludes my talk. Thank you.